your online lecture for Pathologies of the Spine. I am Dr. Cosby, and today we will be using Harry, the skeleton, to help us dive deep into spinal anatomy and then into the pathologies that will plague the spinal column. I think these are important injuries that we understand. Most often they are chronic in nature, but sometimes you may have a rare case where you have an emergent situation arise as a result of some type of contact to the spine that causes your patient to either lose consciousness, head injury, right? Or causes your patient to lose feeling in their limbs, right? So spinal injury. So it becomes important to understand the spine, to understand its role in the human body. In doing so, it will allow you to become a better evaluator of patients who walk into your clinic with back pain. So I'm going to start with the very basic and assume we know nothing. We have three really spinal sections or segments, right? The first spinal segment and the most proximal spinal segment is going to be the cervical spine. And the cervical spine is comprised of 7 cervical spinal bodies. And then what we need to know about this is that cervical spine number 1 and number 2 are special. They actually have specialized names, the atlas and the axis, and are known as what is called the atlanto-axis joint. And so these two, C1 and C2, are hugely important because what we know about the relationship between C1 and C2 is that it is extremely intimate. In other words, C1 is always pivoting or rotating about C2. And it's because of this relationship that we're able to rotate, right? So in essence, it's that rotation of C1 across C2 that allows for cervical spine rotation, right? So we have 7 spinal bodies in cervical spine, and then as we progress to the middle of the back, we have the longest or largest spinal segment, which is known as the thoracic spine. And the thoracic spine is comprised of 12 thoracic spinal bodies. And then as we progress more distally, last but definitely not least, we have the lumbar spine, which is comprised of 5 lumbar bodies. And what's interesting about each of these is the way that I remember how many cervical bodies are in each spinal segment is the way that I kind of eat my meals. So I eat breakfast at 7 o'clock, so cervical spine has 7 spinal bodies. I eat lunch around 12 o'clock, right? And so that thoracic spine is going to have 12 spinal bodies. And then most people traditionally across the country eat dinner around 5. And so then you have 5 spinal bodies within the lumbar spine. I think what's really cool to note about the spine, and the more that I teach and lecture on the spine, are the curvatures of the spine. And so I'm going to blow up this slide just for a quick second to allow you to get a closer look at the way that the spine is shaped. So when we look at the spine, right, there are 2 different curves typically that occur across the entire spinal column. In our cervical spine and in our lumbar spine, they both have what are called lordotic curves. So in essence, we can see that it's caving inward, right? We can see on this skeleton that this lordotic curve is curving inwardly towards the anterior aspect, right? And we see that here in the lumbar spine, most often not as pronounced, but certainly there. And then we have the thoracic spine, which has what we call a kyphotic curve, right? And so each of these curves is instrumentally important in force transference. So let's take a look at the pelvis, right? So if we're looking at the pelvis, one of the things that we know about the pelvis is that it's a central part, right? It's kind of like chopping the body in half right at the spine. Essentially, that pelvis sits central to the head and to the feet, right? And so essentially what happens is as force moves from the lower limb to the pelvis, the next direction that the force is going to move, you guys, is through the spine, right? But could we imagine if we had a flat spine, right? So let's say we have this flat spine. Force would just leave right from that pelvis and drive directly to the skull. And in some cases, this truly could be what life looks like, right? We could totally have a patient come into our clinic with a flat spine, and then what they would be complaining of is what? They would be complaining of migraines, tension headaches, base of the skull headaches, right? And so we are thankful that we have these curves in the spine, because what happens as force gets transferred from the pelvis is it's redistributed, right? Equally and evenly before it actually hits our skull. Does that make sense, guys? And so this lordotic curve and this kyphotic curve and this lordotic curve are extremely important in redistributing and decreasing the amount of force that's going to be applied to the skull, right? Could be applied to the skull to flex it, could be applied to the skull to extend it or rotate it, right? But certainly we're happy that we have these curves. The question becomes, what happens if we have extremes, right? We have a patient who doesn't have the curves, or we have a patient who has too much of a curve, right? Then what are the implications for those particular individuals? So as we progress through this PowerPoint, one of the things that I think is instrumentally important is not just understanding the bony anatomy. I am certain that in gross anatomy, you probably have seen the neural outlook, and if not, let's talk about it for just a second. So when we're thinking about nerves and how they're immunated or displayed throughout the body, you're looking at that image on the right-hand side of the slide, and what we can see is that there are a vast array of nerves that do what? That literally arise off of the skull, right, or the spinal cord, and then supply the rest of the body. We would call those nerves cranial nerves and peripheral nerves, right? And essentially, it's forces that happen to the spine that can impact, right, the way in which these nerves function. And I'm thinking more so about patients who have suffered from a mild traumatic brain injury, right, or a concussion, as some might call it, who have now long-term signs and symptoms as a result of injury that happened to the cervical spine. So it becomes important when we talk about the spine to not miss or leave out the neurovascular bundle that's so important in supplying the rest of the body, whether that's the cranium or the actual entire rest of the body. Okay, so very quickly, today we're going to talk about pathologies of the spine and probably the most general pathologies of the spine, so that you at least have a baseline understanding and you can evaluate patients who walk into the clinic. And so our first anatomical structures that we're going to talk about, which are ligamentous in nature, are the posterior and the anterior longitudinal ligaments. And so those ligaments, as you can see on the slide, you have your anterior longitudinal ligament, which is going to be, so if I move this skeleton, if I were to remove this cage, the anterior longitudinal ligament is going to sit right here, right? And then you can see that posterior longitudinal ligament, which is going to sit posterior to that. What we know about the PLL and the ALL is that they are preventative ligaments, right? Just think, what is the role of a ligament? It's to hold a bone to bone, right? It connects a bone to a bone. So in this case, this anterior longitudinal ligament and posterior longitudinal ligament are going to be major stabilizers in holding our spinal bodies together, right? And we can appreciate that, because if they get lax, then what we get is intra-segmental spinal body laxity. In other words, we increase the amount of movement of our spinal bodies, and we don't want that. We don't want laxity across segments. In fact, we want the spine to stay intact, right? And so these ligaments in particular have been known to resist either trunk flexion and or trunk extension, right? And in some rare cases, right, we do have those rare cases where we have, let's say, a contortionist, right, who we know obviously has to have a lax anterior longitudinal ligament and posterior longitudinal ligament, because they can do things with their body that most people can't do, right? And most often it's truly because these two ligaments are just so lax that they're able to extend backwards more than most or flex forward more than most, because they don't have that resistance from those two ligaments, right? And then last but definitely not least, one of the things that we have to talk about, two of the things that we have to talk about before going into injuries is the different shapes of the spinal bodies across the segments, and then the disc. So let's go ahead and start with the different shapes. As you're looking at your slide, one of the things that I hope you're seeing on this slide is that the size of the spinal body differs. That as we progress from a proximal position on the spine to a distal position on the spine, that spinal body gets larger and larger and larger as we move distally. And we could kind of make assumptions for why that is, but the major reason has to do with the amount of force being applied to each and every spine, right? There is very little force being applied to the cervical spine on most days, unless, of course, you are spending time on your head, right? So if I'm doing a headstand, for example, then certainly more force would be being applied here at the cervical spine than at the lumbar spine. But how often do we spend time in a headstand? Very, very, very rare. What we do spend a lot of time on are our feet, right? We spend a lot of time on our feet. We spend a lot of time seated, right? We spend a lot of time maybe running or jogging, where most of the force that's going to be transferred is most often going to impact the lumbar spine. So that lumbar body has to be a lot larger, right? Because guess what? More forces are going through it. So as we progress from a proximal position, two things to note. Number one, the cervical spinal body is extremely small. And then number two, if you're looking at your image on the slide, you'll see that those transverse processes are very small as well. What's that mean? There aren't very many muscles or ligaments that attach to this particular spine. We know about this spine is that a lot of our neural components emanate from there, but you don't have tons of large muscular attachments. As we progress to the thoracic spine, one of the changes you'll see is there's a larger spinal body when compared to the cervical spine, but that those transverse processes get larger and longer or wider and extend out laterally. And the reason for that is because it's going to receive the muscles of the erector spinae. So it's going to receive your iliocostalis. It's going to receive your longissimus. It's going to receive your spinalis, right? And so for that reason, because we have more muscle and ligamentous attachments, it's going to have these larger extensions because we have to have something to attach those muscles to, right? And then it has a larger spinal body when compared to the cervical spine for the simple reason that when the force leaves the lumbar spine, it's coming to the thoracic spine, right? Then last but not least, the lumbar spine has the largest spinal body. You already know the answer to that. It's because it's taking force from the lower limb and transferring it to the next spine above it. And then like its counterpart, the thoracic spine, it does have larger, wider, longer extensors off of the transverse process. In other words, the transverse process is going to extend it laterally a lot more than the cervical spine. And again, that's for the same reasons as the thoracic. It's going to have more muscular attachments. It's going to have more ligamentous attachments. You guys saw the thoracolumbar fascia, right? So all of those items are reasons that we see differences across the three different spine segments regarding the size of its spinal body and regarding the length or width of that transverse process for each of the spinal segments, okay? Last but not least, before we get into pathologies, we're going to talk about disc. Discs sit in between each spinal body. So if we could look at this, right? So let's look at this skeleton here, and maybe we could zoom in just a tad bit to the skeleton. Okay, so as we do this, as we zoom in, what I want you guys to focus in on is these little clear kind of disc-like structures here. You can see them, right? They're sitting in between each of the lumbar body. So I'm in the lumbar spine, number one. And so if we're looking at this backwards, this is lumbar spine number 5, 4, 3, 2, 1. And in between each of those spinal bodies, what do we have? You see it? We have a disc, right? So let's take that and make it a little bit larger so that you can actually see it. There you are. So lumbar spine number 5, 4, 3, 2, 1. In between lumbar spine number 1 and 2, we have lumbar spine disc number 1. In between lumbar spine number 2 and 3, we have lumbar disc number 2. Hope that makes sense, guys. So each of these discs sit in between each of the spinal bodies. Now I'm just doing lumbar spine, I'm focused there, but you can see as we move up into the thoracic spine, certainly also have disc there as well. So what is the role of the disc? It is just like the meniscus in the knees, you guys, in that its major role is to do what? To reduce shock absorption, right? To reduce friction across bony prominences, right? And so here's what I'm going to say to you as I zoom out a little bit. What I'm going to say to you guys is that if we have compromise to the disc, right? Just think about that. If we have compromise to our disc, then one of the biggest concerns is going to be, number one, the biggest concern is going to be injury to the actual bone itself, right? And the other concern is going to be whether or not force is going to get distributed the way it needs to get distributed if our discs are injured. So let's talk injured. So let's go ahead and talk disc anatomy now that you can at least see what the anatomical structure looks like. Okay, so here we are, guys, back at square one. Hopefully you can see me okay. So when we're thinking disc, I like to think of a waterbed, essentially. So when you lay on a waterbed, you know it does this like kind of thing, right? A disc is very similar. That waterbed has like a plastic sheath keeping it in. Well, imagine that plastic sheath is your annulus fibrosus, right? And the fluid inside of the waterbed is then the nucleus pulposus, right? And so this is a very intimate relationship, right? If that plastic breaks, if that plastic gets a poke in it, then what happens? The water is allowed to spill out. So the way that I think about disc pathologies is very similar, that if that annulus fibrosus gets stretched, if there's a tear in it, then that nucleus pulposus is allowed to slip out and leak out, and that leads to what are called disc pathologies and or disc injuries, right? And that's not ideal, because what we know about that nucleus pulposus is that it can leak out posteriorly into the spinal cord and cause spinal cord issues, okay? So as we progress, we'll now talk about pathologies, and I'm going to try to break them down into their respective spines, if that's okay. And so with lumbar pathologies or lumbar spine pathologies, we have to think about the most common types, right? That's kind of how I like to think about injuries when I'm looking at a segment is what are the injuries that could happen, right? Okay, so common pathologies for the lumbar spine are going to be number one, intervertebral disc, right? So we just talked about the disc just a second ago. Intervertebral disc. Could it be that our major shock absorber is compromised? Could it be that the annulus fibrosus is torn? Is it that the nucleus pulposus is actually leaking out? You can have those facet joint injuries. Remember, talked about the thoracic and the lumbar spine and how muscles and ligaments attach there. So do we have a facet joint injury? Do we have a ligamentous injury? Is it muscular? Is it nerve root, or is it the actual spinal cord? So I mean, that's just a laundry list of injuries. So let's dive deep. In terms of spinal flexion versus spinal extension, different injuries can happen, right? So let's think about injuries that can happen with spinal flexion. If I'm in spinal flexion, I could certainly strain and or sprain a ligament or a muscle, right? So if I strain it, I'm going to be straining a muscle. If I sprain it, I'm going to be spraining a ligament. What we know about disc pathologies is most often they happen in a flexion moment, okay? We can have fractures of the spine. We'll talk about that a little bit later. We can have dislocations of the spine, and then most common, I'm going to say, is some type of ligamentous sprain. So we're going to talk about all of these as it relates to injury and pathologies to the lumbar spine. But let's talk about repetitive extension injuries. So we've talked a lot about repetitive extension injuries. We know is that if you are a gymnast, you're spending a lot of time either on rotation extension or extension, right? So a lot of the injuries that we see happening most often are going to be repetitive in nature. So we're thinking stress fractures can happen there. Facet syndrome can actually happen there. And we're going to talk about spondylopathies in just a second. And last but not least, we certainly could have ligamentous sprains, but most often it's facet syndrome that we see and stress fractures or some type of injury to the actual spinal bone itself. All right. So with a low back sprain or strain, most often that's as a result of either an extension moment, but it certainly could happen if you're flexing and rotating, right? Because you're going to be stretching those muscles. In terms of signs and symptoms, give it to me. It's pain with what? Active extension and most often passive flexion, right? One of the things that I think is important and is highlighted in yellow on your slide is this idea that there's no radiating pain. The pain is very focal, right? And so if a patient comes into you complaining of pain in the knee, you're not thinking muscle strain, right? You're thinking nerve pathology, right? In terms of management for a strain, it's simple. We've talked about this for the other segments, but essentially it's going to be that RICE. It's going to be rest, ice, compression, elevation. I've seen some physicians in the low back prescribe like a muscle relaxant, especially if there's a spasm associated with that. And so you can definitely have that patient on some form of NSAID if you wanted to, and certainly after they have healed, place them on what I would say is a core strengthening program, okay? All right, let's go ahead and talk herniated disc, because herniated disc most often, if they're going to happen, will happen in the lumbar spine. And again, that's because there's so much load being placed on the lumbar spine on a daily basis. I think the research says something like over 40% of adults are walking around with a herniated disc. Whether or not they know it is a different story. It may not be symptomatic, but it's because of the innate position of us to be standing pretty much all day. As you can see on the image in front of you, essentially what you're seeing is the nucleus pulposus has protruded through the annulus fibrosis, right? And so when that happens, that fluid is allowed to leak, and most often it could leak into the spinal cord. So we're going to talk about different types of disc herniation so you can truly get a good understanding for the level and severity and urgency depending on the type of bulge or herniation that you might actually have. Okay, guys, so normally, like I said, the nucleus pulposus is going to be extremely central, right? Like, think about that. It's going to be extremely centralized within the annulus fibrosis, right? But essentially what happens is, as a lot of the forces are being brought through the lumbar spine, what we'll typically we'll see is that fluid kind of squishes, right? Kind of like a jelly donut, I guess. And so essentially, as we take a load, it squishes the nucleus pulposus, and then as we take off the load, that nucleus pulposus will centralize itself again. But if we have an injured annulus pulposus, that doesn't always happen. In essence, what could happen is, as we load, we could have something called a prolapsed herniated disc, which essentially means you can see that annulus fibrosis is ruptured, and so that fluid is allowed to kind of leak through the disc, and that can cause spinal issues, right? You can also have an extrusion. So what that means is, like, you have some part of the fluid that either gets trapped in the annulus fibrosis or stays out there and applies pressure to the cord, but then comes back and centralizes itself. That patient's still going to be symptomatic, right, guys? Because that fluid is compressing that spinal cord. Even if it's for a moment of time, it's still enough to elicit some sort of sign and symptom. And then the one that you're really concerned about is what's called a sequestered herniated disc. So you can see how that fluid, there's still fluid central, but that fluid is now starting to leak down the spinal cord, right? And so the implications for this is that as that fluid travels more distally, or it starts to invade other components of the spinal cord. So that would be what we consider kind of like a medical urgency. Most often the physician might have to go in and surgically either remove that disc and do a discectomy. Really just depends. Okay. So in terms of intervertebral disc herniations, what we know about the mechanism of injury, most often it's caused by a rotation with a forward movement or forward movement, and it doesn't have to be acute. It could be repetitive, redundant over time. So a patient who's doing a lot of repetitive flexion moments. What we know about patients is that most often these are the patients who report to us with some sort of like faulty mechanics. So in essence, like they're just spending a lot of time in excessive flexion and rotation. So an example of this, right, our construction workers, I certainly see this a lot in gymnasts In our pole vaulters, we see it a whole heck of a lot as well. It's because either they just don't have a strong core, and so then the disc is taking over, right? The disc is absorbing more of the shock than it should because they don't have the strong core to kind of stabilize, right? And so then the disc just kind of gives way. You can also have a disc injury as a result of a traumatic injury, right? So literally, like if you think about pole vaulters, for example, when they go up and they pivot and they go over the bar, a lot of times you'll see that kind of violent twist, and then as they're going down from the bar, you'll see them kind of flex and rotate to not hit it. And so you'll see pole vaulters a lot of time will suffer from this particular pathology. But in terms of mechanism, it could be poor posture, it could be faulty mechanics, so excessive flexion and rotation, or it could be a traumatic incident as well. But what we most often see, disc herniations most often are associated with poor posture and the faulty mechanics. In terms of signs and symptoms, so they're going to have pain and then numbness and tingling that radiates into the extremity. So remember we just talked about, what did we just talk about? We just talked about muscle strains of the lumbar spine and how if a patient has a muscle strain, they won't have pain that radiates, right? We just said that. Now we're saying the opposite of that here. So here's a differential. Is it a strain? Is it an intervertebral disc herniation? Well, the differential is, do they have numbness and tingling that radiates into the extremity? That would be like one of my first historical questions is, do they? And then if the answer is yes, okay, we've just ruled out muscle strain, right? That's one thing on our list of pathologies, right? That we can absolutely rule out. The other thing that we know with patients who have a herniated disc is that when they go to flex, they either have anxiety about doing that because it usually increases their signs and symptoms, in particular that numbness and tingling that they're experiencing. On the upper right hand corner of this slide, what you're going to see is a straight leg raise. What we know about the straight leg raise is as we continue to raise that leg, it's going to stretch which nerve? Right, it's going to stretch the sciatic nerve. And so if they have a lumbar or intervertebral disc injury, what you're going to see is as we increase the straight leg raise and dorsiflex the foot, it's going to cause radiculopathy or that numbness and tingling. And then last but not least, depending on the type of disc, so if it's a sequestered disc or a prolapsed disc, then most often what you'll see with that is when you're testing the deep tendon reflexes, that they will be diminished. In other words, you know how the physician does the reflex on your knee and you kick out? Well, their knee extension moment may be delayed, it may not happen at all, or it won't be as much. In terms of management, it's really going to depend on the physician, to be quite honest. I've seen physicians treat this way conservatively, like the patient's in a back brace for 8 to 12 weeks, and then I've seen some physicians say, just finish out your season. But the common goal in the treatment is that we're resting the disc, right? So what can we do to rest the disc? That's going to depend on the sport, right? If I'm a gymnast, I certainly probably should be pulled from my sport. But if, for example, I don't know, I'm a swimmer, maybe I don't need to rest as much because there's not as much force being placed on that particular disc. So it really is going to be sport dependent, you guys. We're going to strengthen the core. I think I'm going to say that a lot during this particular segment. Core strengthening is going to become very important. And then last but not least, surgery may be required, particularly in that sequestered disc, because the fluid is now starting to progress into the spinal column. So here is an example of a lumbar disc herniation. Do you see it there? That looks like maybe a prolapsed disc. But so you can see how that prolapsed disc is actually going to compress on that nerve root and cause numbness and tingling and radiculopathy. So this is what it's going to look like. You can see it here, right? In most discs, like do you see the disc here? You don't see it progressing or protruding. Then if we look upwardly, you'll see it again, right? You'll see that protrusion of the disc into the spinal column. And so that's why it becomes important to rest them to see if we can actually centralize it. One of the great treatments that has been used clinically to kind of resolve disc issues is traction. And what we know about traction is as we pull the spine apart, it will cause centralization of the nucleus pulposus. Even if it's for a few minutes, that allows for symptom relief for our particular patient. Sciatica is a general catch-all term, a name for inflammation of the sciatic nerve itself. You guys are learning this and have learned this, but the sciatic nerve, right, is a large nerve. And the hard part about the sciatic nerve getting impinged or compressed in the spine is that then it has implications down the spine, right? Because we know that the sciatic nerve then branches into the tibial nerve, right? And then the tibial nerve is going to supply the deep posterior and the posterior compartment. So it becomes important to not just understand, like, if it's compressed at the spinal level, but then what does that mean for everything else moving distally, right? So the etiology most often for sciatica is some type of nerve root compression, and it could be due to 3 of the following circumstances. Number 1, a disc herniation, right, which we just saw. It could be that the sciatic nerve is actually impinged within the actual intervertebral foramen. So in other words, like, you have osteophytes that are building up inside of the spinal column, and as a result, it impinges the sciatic nerve. And then the one that I've seen the most, believe it or not, is as a result of a tight piriformis. So that piriformis is impinging the sciatic nerve right here in its space on the gluteal region or the gluteal folds of the pelvis itself. So you're going to have to figure out which of these causes is the root of the numbness and tingling, and then that kind of helps you resolve it, right? If it's a disc herniation, we're going to avoid trunk flexion. We're maybe going to rest. We're going to do some traction. If it's a stenosis, not much we can do. That's probably going to be surgical intervention. And then if it's tightness of the piriformis, clearly we can stretch them or put our elbow in their glutes and hopefully kind of cause a muscle release or use active release to release that piriformis. In terms of signs and symptoms, what we know about signs and symptoms of the sciatic nerve, I've had one, that's why I'm laughing, is if we look at the differences, right? Number 1, you're just going to have this sharp shooting pain and this numbness and tingling that intensifies or increases with that straight leg raise test. Most often that pain could go all the way down into the foot. Why? Because what we know and what you guys have learned in the compartments assignment is that sciatic nerve, even though it's a sciatic nerve proximally, becomes so many more different things distally, right? And so it could certainly impact the entire side of a patient, right? And so we have to kind of take note of that, to take note of where the symptoms actually stop in terms of location, and whether or not it's traveling more distally as the pathology progresses. In terms of management for this one, in particular, it's rest. It's removal from the sport. It's avoiding leg or hip flexion, because if we avoid hip flexion, then we avoid stretching. And then what we want to do is figure out how to treat it, right? And that's really going to depend on the etiology. Is the etiology as a result of a disc herniation? Is the etiology as a result of the stenosis, or is it as a result of the piriformis, right? So you have to first figure out why, and then that helps drive your treatment protocol, you guys. Okay, let's talk spondylopathies. What we know about spondylopathies is these are injuries caused by repetitive extension, in particular of the lumbar spine, okay? So I'm going to say that, and then we're going to go right into it. There are 3 grades of a spondylopathy. The first one is a spondylolysis, okay? So the first grade, grade 1, spondylolysis. You have degeneration, right? Usually degeneration of the spinal body. No big deal. That's going to happen to all of us. Welcome to getting old. Then you have a grade 2, which is a spondylitis, which means you actually have a fracturing. Most often that fracturing could occur to the spinal body. It could occur to the spinal process, right? And then last but not least, we have a grade 3, which is the worst case scenario, and that's a spondylolisthesis, okay? And essentially what happens is you have this kind of bilateral fracturing, which leads to, can you guys see this? The slipping of the vertebral body anteriorly, okay? Because there's nothing to hold it. There's nothing to hold it back. So what's the etiology? Most often, it's degeneration of the vertebrae. So in other words, we start with a spondylolysis, a grade 1, right? But essentially that progresses into a lysis, which is a fracture, and then it could essentially lead to a slipping forward of the vertebral body. And I'm going to show you the next slide so you can get an image of what a spondylolisthesis looks like, okay? So a spondylolisthesis is the worst. It's the grade 1. It's where we have this fracture and then the spinal body slides anteriorly. And there are major implications for that. The spinal body is slipping anteriorly. It's going to impinge on things, in particular the spinal cord. But what we're going to see essentially is, if you're looking here, as that fracture piece happens, essentially you see this kind of sliding down anterior of the spinal body. So the signs and symptoms of a spondylolisthesis are extreme amounts of low back pain that don't resolve themselves. And when I say resolve, usually with low back pain, you could put ice on it, stretch it, massage it, it goes away. But with a spondylolisthesis, this particular patient is going to complain of pain that doesn't go away. Almost think about it like the night pain in a stress fracture, right? They're going to have pain with activity, but they're going to complain of increased amounts of pain post-activity. And then if the slide is anterior enough, if the slide forward is anterior enough, on the posterior side of the back, when you palpate the spinous process, you might actually feel what we call as a step-off deformity. So when you're palpating, that spine is no longer there, right? Okay, so let's take another look at this here. We're looking at spondylolisthesis, right? So if we have a fracturing, can you guys see that okay? If we have a fracturing here, you can see how that L4 has slid forward, right? So the S1, L5, L3, all in a line, but can you see how L4 has kind of slid forward and dropped down onto L5? So this is just an example of a fracture of the pars interarticularis. In terms of management, one of the things that we do a lot with these individuals once the fracture begins to heal itself is truly focusing on the core stability, truly focusing on trunk strengthening, truly focusing on abdominal strength, right? What's the moral of the story? We need to make sure that their core, their abdominal region, their back regions, their obliques are strong enough to take away the force of the disc, right? If we have a stronger core, we're not loading the disc as much, and the disc doesn't have to do as much work, and we're not loading the bone, right? Which means essentially we have to do something to take off the pressure from the disc, and which will essentially take off pressure from the actual bone, from the bone itself. Okay. The other recommendation is to avoid lumbar spine hyperextension. So you can kind of see this here. They'll be placed in a rigid back brace. Most often, if surgical intervention is not necessary, this is on for like 8 to 12 weeks, sometimes longer, depending on the actual physician itself. Really just depends. Again, you can see that spondy, see it there, right there. And then you can see how the screws have been placed in to bring it back into alignment. Okay, so remember your cheat sheet. These are spine injuries by motion, right, or by etiology. So let's go ahead and move on to the cervical spine. The cervical spine, as you can see it here, but where is it? Okay, so we were thinking about annulus, the anterior longitudinal ligament and the posterior longitudinal ligament. My goodness, right? You can see that this person has neither of those. All right, so cervical spine guidelines. Let's just go through a few things here, but we're going to spend more time in our clinical class discussing this. If you have an injury to the cervical spine, you must rule out C-spine injury, right? So the first thing is we consider all cervical spine injuries to be catastrophic, first and foremost. Like before we even start with muscle strain, muscle spasm, evaluation, we have to rule out catastrophic injuries first with the cervical spine, right? Because it's life-threatening if not. So we want to do a neurovascular analysis of our patient, and then last but not least, we want to palpate all of the spinous process. If they are tended to palpation on that spinous process, then we are referring out for an x-ray just to make sure the spine and the segmental stability are intact. Does that make sense? What am I saying to you guys? Please do not perform a cervical spine evaluation until you've ruled out a fracture. Because if you move the spine and they have maybe some segmental instability, that spine could slide forward and now you have compression of the spinal cord. So always make sure you've ruled out a spinal injury fracture before you actually start your evaluation. Did I scare you? Good. Okay, so mechanisms of injury. There are several different mechanisms of injury that can cause cervical spine injuries. And the funny thing is, I'm looking at this slide thinking of my 2080 Karen Virgin class where I make the students actually do this. But this slide is not for this case right now. I want you guys to actually visualize the different loads that can occur to your patient that can cause a cervical spine injury. And then which of these do you think would be the worst case scenario? Which of these would lead to the most catastrophic injury? Great. I'm hoping that you said that flexion potentially, right? Flexion moment. So number 2, right? And then that flexion with rotation moment has been known to cause catastrophic injuries, right? And if you're in football season right now, I'm hoping you're cringing at the thought of all of these, right? Because your linemen are going to be at increased risk for cervical spine injuries, right? They're putting their neck at most risk, right, when they're butting up and protecting that running back or protecting that quarterback, right? So these are all mechanisms of injury. You can have an axial load, so a load to the top of the skull. You can have a hyperflexion moment, hyperextension moment, right? Rotation moment, lateral flexion moment, or again, I said axial load already. But here's what I want to caution, because even though you're not in a high school rotation yet, one of the things that I want to caution you for is if we could design the worst position, right? The worst position for a C-spine injury, it would look something like this. Do you guys see that? Where the head is somewhat extended and we're applying an axial load. And what we can see in this image, you guys, is that there's just no give. And so the force gets distributed centrally to that cervical spine and it ruptures. And it causes a spinal cord injury. And we don't see this injury happening as much in football anymore. But before we had standards for tackling across the board from NFL all the way down to Pee Wee, we were seeing burst fracture injuries happen often. And now, of course, the Safety Council has kind of created these standards which teach coaches how to teach students, athletes how to tackle. And so we're seeing less and less burst fractures. But this would be the worst case scenario, right? Okay. So in terms of cervical cord and nerve root injuries, right? So cervical cord and nerve root injuries, the etiology is going to be, could be different. It just really depends. But mechanism includes some type of like laceration to the cord or the nerve root. Most often it's going to be some type of contusion. Certainly could occur as a result of a tractional moment, so that cervical spine gets stretched, or a compression moment as well. So when we're thinking about the cervical cord or the cervical spinal cord and the nerve roots that emanate off of it, remember I talked about this early, but I'll certainly show it to you now. So for here, right, remember I said that these nerve roots come off of the cervical cord, so they can get pinched, they can get stretched if I'm pulling, right? There's a lot of things that can actually happen. In terms of signs and symptoms of a cervical cord or a nerve root injury, it depends on the level of the injury. I hope that makes sense, right? C1, C2, C3, all the way down to C7. So your patient's signs and symptoms are going to vary. What I can say is think about it this way. The higher the injury, does that make sense? The more signs and symptoms that patient is going to have distally. And then the lower the injury, right? The less signs and symptoms per se that might be impacted. So one way to think about this is it a cord or is it a root injury? In other words, is it a spinal cord injury or is it a root injury? If it's a cord injury, right? So spinal cord injury, then the signs and symptoms are going to be bilateral. So that patient will come in and say, I have pain on my right and my left side. If it's a nerve root injury, does that make sense? If it's just a nerve, then they're only going to have pain on one side. So that patient's going to come in and say, I have numbness and tingling on my right side. If I say numbness and tingling on my right and left side, then we're thinking, okay, the spinal cord has to be impacted, right? Because both nerve roots are compromised, okay? One thing to think about as you guys enter into football season is this idea that cord lesions above, at or above C3, so C3, C2, C1, right, can result in death. And that's all about what? The spinal cord controlling the entire body. Injuries below C4, even though they might have more symptoms, at least that patient will survive. And so we have to think about when we approach a patient with a head injury, making sure we rule out those injuries between C1, C2, and C3. Remember, C1 and C2 are atlanto-axis joint. They control rotation of the spine, certainly, but the concern with a C1, C2, and C3 injury is what, you guys? It's this idea that it's so close to the brain. Does that make sense? As we progress distally, we might have more peripheral signs and symptoms, but we certainly are further away from the brain, and so as a result, the risk of death is reduced, if that makes sense. I'm sure I'm making sense there. Okay, cervical fractures can absolutely happen. If they happen, they most often happen in college football. Just throwing it out there for you guys, not trying to jinx you. It's commonly as a result of what you can see there. So there's an axial load, right, from the tackler, and then you get some cervical flexion that's associated with that injury. So if you're tackling, if you are a lineman, you're spending a lot of time in this particular position. This is the position of what I call is the point of no return. So essentially what you have is an athlete butting his head up against a force, and so as a result, you most often surgical fracture, right? Signs and symptoms, point tenderness to the spinous process of the patient. So let me show you what I'm talking about when I say spinous process, just so we're on the same page here. So they're going to have point tenderness right here, right on this spinous process, right? So when we touch, they're going to hurt, right? They'll have muscle spasm in the facet region. So they're going to have muscle spasm on each side potentially, makes sense? And then they're going to have numbness and tingling. They're going to have numbness and tingling and or weakness in the limbs and the trunk, right? Because that fracture most often is going to impinge a nerve root or two, and so they might have weakness in flexion or extension. It just depends on the nerve root that's going to be impinged. One of the concerns, though, with cervical fractures, depending on how high that fracture is the patient could actually lose their bowel or bladder. So you'll know that. You'll see their pants are wet, not from sweat. And so that's a concern, right? Because essentially what that means is it's impinged on the quadra equina, which is one of the neurovascular bundles supplying the bladder. So in terms of management, 911, and we're going to spine board, and you guys are going to learn how to spine board the first week of classes. I'm excited to do that with you, but you're actually going to spine board. And the rule of thumb now is if there's any loss of consciousness, we're actually going to spine board and cart and send them on their way just to make sure we're not missing anything. Cervical dislocations are somewhat rare. I don't think I've seen one in 15 years of clinical practice, but that doesn't mean they don't happen. Cervical dislocation occurs as a result of flexion and rotation moment. So if you are on the football field or any other contact sport field, mainly football, and you see a violent flexion, rotation of the head, and they have pain and numbness and tingling immediately, then you're suspecting that maybe there was a cervical spine dislocation. Most often, the dislocation is going to be unilateral. So what do I mean by that? It's one side, so the head is going to tilt, and so then you'll have muscle spasm on the opposite side. Does that make sense, guys? So if I dislocate and my head tilts, my spasm is going to be on the side of the tilt, if that makes sense. So you're going to be looking for spasm on the side opposite the dislocation. They're going to have numbness and tingling because what happens is as they're spasmed and as they're tilted, that's going to compress on the peripheral nerve and cause neuropathy signs and symptoms. So what do we do for them? One of the things that's of concern, and I didn't say this with the fracture, but I want to say it with a dislocation, is that movement can actually cause further dislocation. And so you want to be extremely careful with this. If you suspect a patient has a dislocation of the spine, then essentially what we're going to do is spine board them and refer them or call 911 and have them cart them, because we don't want to cause more movement, which could lead to irritation of the spinal cord itself. So we want to be very careful. With a suspected cervical spine fracture and dislocation, I think I've been saying this, but if I haven't, please know you're not supposed to perform any evaluative techniques. So no range of motion of the cervical spine, right? Especially if they have numbness and tingling or had it, because again, you don't want to cause any movement of that bony process. So this is the one time where I'm saying, okay, stop your evaluation. There's numbness and tingling. They had a flexion rotation moment. Stop your evaluation and just send them out. Now you guys are probably like, Dr. Cosby, you tell us to send out a lot. With cervical spines, I'm the most conservative. Usually I'm an aggressive clinician, I think. But when it comes to the cervical spine, there's just so much that can go wrong that I'd rather refer out and let a physician make the decision than for me to make that decision for my particular patient. Spinal pathology is one that you're going to see or encounter a lot in football, and it's a brachial plexus neuropraxia, or what most athletes would come off at the field and say is, I have a stinger, right? I'm sure we've all heard that at some point in time in our life. So if you have encountered this patient who says, oh my gosh, my shoulder's burning, most often coaches will call that a stinger. So the result is, the etiology is as a result of a stretching of the brachial plexus, right? So let's look at that here. So we have these nerves coming off of the cervical spine. Essentially, in terms of mechanism of injury, most often there's a lateral flexion. I'll do it here. There is let's make this bigger. So essentially what happens is there is a lateral flexion moment, and that lateral flexion moment, as you can see, is going to cause a stretching of the nerve roots that are running through here, right? And so when you laterally flex and have a shoulder depression moment, essentially what happens is these get stretched, so do the nerve roots coming off of there. Do you guys see that there? So do the nerve roots coming off of there. And so as a result, that patient reports to you with signs and symptoms that are kind of neurologically driven. And so it becomes important with this particular pathology to not blow it off. And I'm going to try to convince you guys of the why in just a second. But the major reason for this is because they're going to have a stretch to the nerve root, right? And when we stretch the nerve root, what we know about that is it's going to have other roles throughout the rest of the body. And so what we see with a brachial plexus neuropraxia, or a stretch, is that the patient will exhibit signs and symptoms similar to a disc pathology. So they're going to have numbness, tingling, usually into the hands and into the shoulders. But what's most important, and what we see most often with this injury, is that they actually have a loss of strength and function in that arm for several minutes. And so it becomes important to not rush to return this athlete to play until they've restored strength. Does that make sense? So in terms of return to play, they have to have full strength in elbow flexion, elbow extension, shoulder flexion, shoulder extension, right? Because if they're a lineman and they're pushing, for example, does that make sense? They now compromise themselves because they don't have enough strength to do that, right? And so we want to make sure that while we're in a rush to return the student athlete to play, that if nothing else, at minimum, for baseline, that they at least have full strength in the shoulder and elbow functions. Last but not least, we know that a brachial plexus neuropraxia, or brachial plexus stretch, is a small or the mildest form of nerve injury that most often our patients are going to heal from this. But the concern is like when there's these repeat injuries to the brachial plexus, and because sometimes what we see is that can lead to long-term implications. And so there's temporary dysfunction associated with this pathology. Most often it's after some type of stretch and depression of the shoulder. So we want to make sure that with these particular patients, again, we test their strength. It's common in collegiate sports, in particular in football. So what we know is about 65 to 70% of football players will experience at least one stinger during their career, which means you're going to be evaluating tons of them. So in terms of return to play is exactly what I said. Return to play after the symptoms have subsided. Make sure that you're ruling out a fracture to, I would say, radial ulna, humerus, just to make sure, and rule out a shoulder dislocation, right? Because a lot of times shoulder dislocations will have similar signs and symptoms. And then for these athletes that are at high risk for stingers and burners, we see it a lot in the NFL now, and in college they're wearing those cowboy collars to prevent the stretch mechanism from occurring. And then finally, just do strengthening with your linemen. I imagine most college athletic trainers already have this going on, but at the high school setting, if you're going there, I challenge you to create a neck strengthening program for your linemen in particular, because it will reduce their chances of moving into a stretch moment. So I hope this has been helpful. I hope you learned a few pathologies that will plague the lumbar spine, a few pathologies that will plague the cervical spine, and I hope this is helpful for you as you progress in your clinical rotations. I will see you guys in Zoom.